Okay, hi everyone. It's my honor to welcome Dr. Thomas Piggott, a public health and preventative medicine specialist and a practicing family physician who has served as medical officer of health for Peterborough since 2021. Prior to this, Dr. Piggott was medical officer of health and VP lead for population health and rural and remote health in the northern region of Labrador-Grenfell Health. And he also worked as a field doctor with MSF, or Doctors Without Borders. Dr. Piggott has experience in collaborative Indigenous public health in Canada and internationally, and was co-editor of the book Underserved: Health Determinants of Indigenous Inner City and Migrant Populations in Canada. It's a fabulous book. Perhaps I'm biased since I contributed a chapter, but I highly recommend the entire book for those of you who are interested in underserved populations and health equity. And I'll put a link to it in the course. Now, I could go on and on, but I'll leave it there, and I'll link to your bio for the students to read about many, many other interesting involvements and accomplishments. So Dr. Piggott, I've long admired your work and your approach to public health and health equity, and it's a real privilege to have you here today to discuss a whole range of topics relevant to the class, or at least as many as we can cram into our time. So thanks for joining us.
Thank you so much for having me today. I really look forward to it. It sounds like a really exciting class. So look forward to sharing and happy to chat if people have questions or want to reach out afterwards. So.
Thanks so much. That's really kind of you. So I want to start off, if you could just tell us a little bit about what you do as a medical officer of health. What's your day-to-day life like?
Yeah, great question. So I have two hats, two main hats that I wear in the organization that I work for, which is Peterborough Public Health. The first is a CEO, which maybe that is a more clear role for folks. So as Chief Executive Officer, my boss is our Board of Health. Our Board of Health here in Peterborough is composed of elected officials and those appointed by the provincial government. So right now we have two provincial appointees and three county and three city of Peterborough representatives, as well as a councillor delegated from each of Hiawatha First Nation and Curve Lake First Nation, which is quite unique here in Peterborough. We have what's called a Health Protection Promotion Act Section 50 arrangement to serve the First Nations that exists within our boundaries. And so for almost 50 years, there's been an arrangement for service provision, which is fairly unique. We're just one of two health units in the province that has such an arrangement. And it's really important, I think, is very valuable. So as a CEO, I report to our Board of Health. I take their direction and implement it operationally with our team. I lead a team of about 150 people in the health unit, including directors, managers, and frontline staff. So that includes public health nurses, public health inspectors, epidemiologists, administrative staff, dietitians, the list goes on, dental clinic staff. And I'm responsible for, in the CEO role, planning strategic direction and implementing that, working to support our directors to do work and to accomplish some of the goals of public health. So then the other hat that I wear is as medical officer of health. So medical officer of health, or MOH, is a legislated role that people probably knew very little about before the pandemic, but now I think it'd be hard not to know about. It's legislated in the Health Protection Promotion Act that for the region we serve, which for me, again, is this Peterborough Public Health region, I need to monitor health issues and respond to health issues for the population as a whole. So while I went to medical school and did training and, still wear my stethoscope once in a while doing some clinical work, largely instead of seeing individual patients, my patient, quote unquote, is the population that we serve. So I have to think at a population level. So instead of doing tests and treating diseases, we often try to rely on evidence from epidemiology on priorities of diseases, and then interventions at a population level instead of an individual level. So that could include a new program like a home visiting program for young kids to support moms and young kids to develop healthy. It could include a program to implement a big vaccination campaign like the COVID-19 vaccine, or it could include advocacy around policy related issues. And a lot of the most successful public health initiatives of the last 100 years have been advocacy on policy, things like improving sanitation, improving living conditions, improving working conditions and income for people to reduce injuries and reduce disease and improve and promote health. So it's a broad kind of role, but there are specific functions and work that we need to do within it. And in Ontario, there's something called the Ontario Public Health Standards, which set out a bunch of things that health units should be doing and need to report back to the provincial government on whether they do. So that's a bit about it. Day to day, I spend a lot of time in meetings with different people, sometimes internally with our teams leading and providing input. Maybe there's a communicable disease issue or concern, like a new case of meningitis or invasive group A strep, and I have to provide some guidance on how to manage that. Or maybe the team just needs a bit more input direction. And I do a lot of meeting with external stakeholders too, a lot of politicians, leaders of other organizations, especially locally here in the region.
Wow, you've got your hands full. And I think before the pandemic, people just weren't thinking about public health. And then all of a sudden, uh, public health officers got so much media attention. And I think many people thought, oh, their job is just to sit around waiting for a pandemic and then jump in. But really, you have all of these priorities that you're juggling. And then on top of that, enter the pandemic.
Exactly. Day to day, there's a lot that we're doing, and then you layer on the pandemic. And one of my mentors once said, you get a lot of attention during health protection or health emergency related issues, including pandemics. And with that capital, you build capital during the response to these emergencies to spend it on health promotion and health equity work that we do less of when the emergency is the most acute, but especially in between emergencies. But this is not my first pandemic of my short career. I'm still pretty young, but it's certainly the biggest and most noticeable one that folks would have heard about and attention would have been drawn to public health around.
Wow. So I can't imagine what it would have been like. You entered into this role, you previously worked in a completely different context, and you're transitioning during a pandemic. I was wondering if you could just talk about what that was like during, as you said, it's not the first, but a pretty major, a pretty major one that has affected us in pretty unprecedented ways, at least in our lifetime.
It certainly is unprecedented, at least in the last 100+ years. And the last big major pandemic with a death toll anything like this was 1918 influenza pandemic. But COVID-19 is nothing like H1N1, which is the first pandemic of my career, MERS-CoV-2, which was another a pandemic with less concern immediately in Canada, a Zika virus, Ebola multiple times internationally. Um, those are just some of the other pandemics that we've had to be either readying ourselves for or responding to since I've started in public health. But I've also worked internationally, and my first job out of my residency training in public health was in the DR Congo with MSF, in an area where there's a lot of violence and responding to violence-related issues, and quite close to where Ebola was happening. Not focus of our project, but we were doing work on gender-based violence and primary healthcare access in that area, lots of malaria, TB, other complex health challenges. And then after working with MSF, my family and I moved up to Labrador, and we were working in, I was based in Happy Valley, Goose Bay, Labrador, which is part of Newfoundland and Labrador. The region's very large, but not very densely populated. So the population is about 33,000 people. And the region is as big as the United Kingdom, or just a little bit bigger than the UK. It's that part in the northeast of Canada. You may have seen kind of wedged out of Quebec. And it's a region with a large Indigenous population. Half the population that we served identified as Indigenous. There's 4 different Indigenous groups. Inuit government, Nunatsiavut government was one of the largest. There was 2 First Nations, Shaashi and Natwashish Innu First Nations, and Nunatuavut Community Council were the 4 Indigenous groups we worked with there. And that's where I spent the first half of the pandemic so far, was in Labrador. And it was a really interesting and very different experience than coming back and being here, in part because there was so much community concern, because there had been oral history transmitted down from elders who themselves remembered the 1918-1919 flu pandemic. And it was devastating in Labrador. And there's books, including a really excellent book, maybe I could send you the link of, We All Expected to Die, around how Labrador was largely abandoned through the flu pandemic. And some communities had devastating death tolls. Two, Okak and Hebron in northern Labrador, um, uh, were completely decimated. 90% of the population died, and the communities were relocated after the 1918-1919 flu pandemic, because nearly everyone had died in these communities. There's a National Film Board documentary on the last days of Okak, which is really interesting, but a really horrific experience in Labrador in the 1918-1919 flu pandemic. And so I think as a result, people were very apprehensive and worried. So one of the interesting things was we actually had very few cases, only around a dozen cases of COVID-19, cases, not hospitalizations or deaths,
Wow.
cases in a population, 37,000 people, up until the point that I left. They had taken an approach, a policy approach of locking down the borders and restricting travel, which had its own set of complex, some negative consequences, but they had managed to keep COVID out. And it was largely driven based on this fear of the pandemic, from oral history passed down, generation to generation, and elders who, some of whom, either their parents or they had survived this, in the 1918 flu pandemic. And so the experience I had was very different in the early phase of the pandemic. Now, shortly after I left, Omicron hit, and they did get quite a lot of cases. But fortunately, it was after the population was well vaccinated, and the consequences weren't nearly as dire as they otherwise would have been. But it was very different. And then coming back to Ontario, it was interesting. Certainly, the pandemic has been much more politicized. There's been real struggle and tension between responding at a population level with preventative measures to save lives, and the notion of individual freedoms or restrictions on freedoms, which was something that was new to me. And I only just started my job here December 2021, so been here for a little under a year. And very soon after starting my job, there was protesters at my house around some of the communications we were doing and things like that, which was all very different for me and unexpected, because obviously the landscape's so different with the pandemic response here in Canada, in Ontario and southern parts of Canada.
So these protesters were upset about COVID restrictions and they targeted you personally?
Yeah, there's a couple stories, the Star Globe, things like that. But if you want to read more, but what happened was, there was protesting happening at our office building in middle of January, around the vaccination and masking requirements. And these protests had been recurring. One group of protesters actually stormed our office building, broke in. There was charges laid around that, and continuously we would have to increase security presence and send staff home early and modify our work. And so one of the things that I knew from our board when I started was I had to really take a decisive leadership position on protecting our staff, because they were very fearful and worried about this. And so one of the things that happened that I think was probably the reason they ended up targeting my house was I communicated out on social media that, enough already. Instead of trying to manage and respond to this pandemic, we're dealing with trying to protect our building and our staff's safety. And and enough's enough. Like, not to say there isn't the right to freedom of expression, which is obviously critical in our country, but not at the expense of healthcare workers. So the very next day, they showed up at our house and they put up, pasted posters onto my house and said, "You're killing our children because you're vaccinating them," and some of this kind of thing. And they ultimately came back a few days later in the evening. You can read about it if you're interested, but ultimately charges were laid in relation to that, for intimidation of a healthcare professional and criminal harassment. And this was probably the first instance of this Bill C3, which was amendment to the criminal code to explicitly say that intimidation of a healthcare provider is an offense. So it was a bit of a rough start into this role,
Yeah.
and welcome back to Southern Ontario, where I'd been before all this. But at the same time, I think I'm just so amazed by the resiliency of our staff and everyone doing the work in public health. They've been continuing to diligently work on this, and it's tough. I mean, I get the complexity of this, and in no way do I want to count or sell the challenges the pandemic's had on people, on businesses, on families, kids not being able to go to school, businesses being closed down. I think these are really challenging, complex issues that governments, the people in democracies we put in positions to make these decisions, had to navigate. And I think it was hard because sometimes the evidence wasn't clear and the risk was evolving, and it was a changing issue through the pandemic. But overall, I mean, I think we've done incredibly well here in Peterborough, but also in Canada. Sadly, we're at over 45,000 deaths due to COVID-19 in Canada, which, to put in context, is more deaths than occurred in combat in World War II by Canadians overall. So a very large death toll, far exceeding the approximately 3,000 people that die per year from influenza, right? So 45,000 deaths in 2.5 years, far greater a rate than influenza or other respiratory viruses. But the story we don't tell enough is how many lives perhaps may have been saved. And I don't know if you can see my screen if I just share this one figure. Oh, no, I can't share it, but I can send you the link to it. It's just a figure showing how many lives may have been saved
You can share now. You can share now.
through the COVID-19 pandemic. So I don't know
Yeah,
if you can see
we can
this,
see
but
it. Yeah, we can
we
see
did
it.
some modeling work looking at a couple of models on how many lives may have been saved, and so the orange and green plots here in this area chart show how many people may have died. So we've now had over 100 deaths in our Peterborough Public Health region, but we may have saved up to 300 lives through preventative measures, especially vaccination, but the other preventative measures we've taken through the pandemic as well. So it's been tough, but I'm impressed by how well overall, obviously lots of polarization, especially now, but how well overall we've done in saving lives through the pandemic.
It is truly amazing. And it's often said that with public health, if you don't see it and you don't know it's working, but you're staying alive and staying healthy while it's doing its job.
In the
And
background,
yeah,
yeah,
in the
yeah.
background, doing all sorts of things that we might not even be aware of. Yeah, so first of all, I just want to say I'm really sorry that you went through that, and obviously how wrong that is. And it's, especially as a parent, I can appreciate how just really upsetting that must have felt for you and your family. And as you said, not a very nice welcome back to Ontario.
Yeah, and it was, I mean, it was a little crazy. It was right after we'd gotten here. I hardly knew
Yes.
where I lived. I don't know how they figured out where I lived. I could hardly find my way back home. So yeah, it was tough, and it was tough on the family. But I've also had other experiences, and having worked in a war zone and in northern Canada, where the challenges, the health inequities are so much greater. I think I've been able to put it very much in perspective and look at how much privilege I have. We have a lovely, safe home and family and jobs. And so this was really quite relatively minor in the context of other things that I've seen.
Still, it's been quite something to watch. I still remember at the start of the pandemic, everyone was, here in Ontario at least, banging pots and pans every night in gratitude for
For
healthcare
healthcare workers.
workers.
Yeah.
And then as time went on, there were protests against healthcare workers. You weren't the only one, as you know,
No.
hospitals being targeted and patients not being able to get in and healthcare providers not being able to get to work. And it's just been kind of shocking to watch that evolution of attitude with people's anger being directed that way. And I'm just wondering, how can we navigate, or how do you navigate this tension between wanting to protect public health, and sometimes that involves imposing perhaps unpopular restrictions, and then allowing, people to live free lives, even if that means increased risk of illness and death. How do you navigate that tension? And I can't imagine how difficult that would be.
Yeah, no, it is a complex tension. So a few things. I think one is that initial response and solidarity, which I think was so impressive and so much to give credit to for how many lives we've saved and how much we've come together, even though 2022's kind of fallen apart with increasing polarization. I think that that was incredibly important. Um, I think that if I go back to early March, end of February 2020, beginning of the pandemic, I think there was a few challenges and failures in communication. One was that I think we all thought that we were in for a sprint, and the finish line kept moving further and further and further on us. I mean, even I was hopeful that, we'd have a big summer wave and then COVID would retreat. And by fall 2020, we'd be, back to life as normal. And when we set out on a sprint and the finish line kept moving, we were ultimately running an ultra marathon. I think that we lost a lot of people who didn't pace themselves along the way. And I think that that's an unfortunate challenge. And I think, some of the more heavy-handed measures, let's say school closures, business closures, those have been conflated with some of the lighter but still really important measures, which I would say are things like requiring vaccination in public places, requiring masking, at least when the risk is high. I mean, do people need to wear a mask 365 for the rest of their lives? I don't think so. I think masks are going to be more like snow tires when we finally reach a normalization. You don't leave them on the car all year long, but you strap them on when the risk starts to go up again. And that's what we're trying to communicate with our risk index based guidance. Um, so so masks, vaccination, and especially as we know, it's the airborne transmitted virus, improvements in ventilation in indoor spaces. Had we put more emphasis on some of these more sustainable measures, I think we would have had less issue with everything being, baby being thrown out with the bathwater, everything being caught up in this polarization. But I think one significant challenge has been political actors have intentionally gravitated towards this for political gain. And we see that with a lot of the federal Conservative Party of Canada, even with the Ontario election, especially the Ontario Party, and some political actors really trying to emphasize this victim complex as a result of things like required vaccination and masking, which are not really restrictions that are all that disproportionate with other measures that restrict freedom that predated the pandemic. We require vaccinations in schools. There are exemption processes, but we've decided that for routine immunizations, it's critical to create safer school environments to require vaccinations. We restrict where people can smoke. I'm sure I remember the days when you could smoke in a restaurant and then you could smoke in a patio, and now you can do neither. And I think that that has been lost in the black and white polarization of we need to throw all the pandemic measures out. Other things like seatbelts, and I've spent a lot of time reading about the history of requiring seatbelts in Canada. It's an interesting one, but do you have any idea, Janet, when seatbelts were first introduced as an option in cars in Canada? When could you first, if you wanted them, get seatbelts? Any guesses?
1960s.
Very good guess. Mid 1950s. Mid
Okay.
1950s. So, Ford and Chevrolet, a bunch of companies started to say you could, as an option, have a seatbelt if you so desire. And when do you think the last province or territory in Canada required seatbelts? Any guesses?
1980s.
1992, I believe it was, with the Yukon, right? So the first province was Ontario. I think 67 Ontario required seatbelts, at least in the front seat. But the point of that story is it took 50 years of social change, and it was a friction road. I mean, physicians used to get people coming in for exemptions for wearing seatbelts, a note to have an exemption for wearing seatbelts, because truckers would say it restricted their breathing, et cetera, et cetera.
Wow.
And so I think there's a lot of interesting parallels. And to some degree, I'm trying to use that as a way to help to find solace in where we're at with the challenging point in the pandemic. We got a lot of buy-in initially. Politicians have politically polarized the issue, and we've now had refractory, the pendulum swung too far the other way, and people are at risk of getting sick and dying. But I think that it will normalize, and it will take some period. I sure hope not 50 years. I hope it can be much quicker than that, of social behavior change, to get public support for some of these measures. Because the reality with things like masking and requiring vaccinations is that they are measures that don't just impact your own health, they impact the health of those around you. And from an ethical principle lens in public health, when health issues impact the health of those around you, there's a lot more of a impetus to potentially restrict freedoms to protect those around you. And I think we'll get back there. I certainly think in Ontario, we are likely to see required masking in this next winter season at some point. I hope it comes in advance of the more dire situation, because if we wait until hospitals are at their breaking point and full, you've kind of missed the point of the prevention piece. But I also know it's very politically challenging, and in the environment we're in now is one where we actually just in Ontario had an election. And regardless of your political beliefs and what you think about the incumbent re-elected government, they got a strong majority support from the public, from the province. And that Democratic majority support, I mean, is essentially saying we're not willing to do much anymore to protect others around us from dying in the pandemic.
But that
And so
also,
that's something we have to reconcile.
yeah, but it's also partly due to our electoral system
I agree.
where the vote split is leaving all of the progressive parties divided among voters, and actually they're not getting the majority votes. But that's another whole discussion.
And turnout aside too, right? But all these things I think are reflections that that it's a complex time and period we're in now. But I do think that there will be increasing public concern around these issues, especially as people figure out that, there are preventative measures that aren't like shutting down businesses and schools, things like requiring vaccination and masking that really come with very little harms, evidence at least of very little harms, and are going to be potentially not only life-saving for some people, especially older Canadians, but they're also going to be important to protecting the healthcare system. I mean, I had a friend that went in for something that may have otherwise taken a few hours in the emergency department. They were there for like 2 days, and it was very dire. And I think that people need to understand, the public needs to understand how precarious our publicly funded healthcare system is in position right now. And if we don't do some of these more minimally harmful measures, then I worry where we'll be ending up in the next few months.
I share your worries, and we just had a whole lesson on our collapsing healthcare system and the burnout and the challenges with staffing and all of that. But I guess my question is, since the healthcare system is already under stress, since COVID is clearly spreading and we've got these variants that are less responsive to vaccines, et cetera, in terms of transmission at least, why aren't these public health measures coming back? Who ultimately makes that decision? Can you make that decision at a local level? Is that a provincial medical officer of health decision, or is it a government decision? And what happens if you disagree? Because it sounds like what you're saying is these would be helpful measures,
Yeah.
but without mandates, people aren't doing them. When I go into the public, I'm usually the only one masked, or one of few.
Same.
So obviously without mandates, people aren't following these guidelines. We're also seeing people not getting their third and fourth boosters, which are not
Yeah, it's very
required.
concerning too.
So who makes that decision, and what power do you have or do you not have at your level? So that's my next question.
It's a complex answer, but let me see if I can unpack it and share my thoughts, which may differ from other people provincially. The Health Protection and Promotion Act, which is the legislation that governs public health in Ontario, has a number of authorities. And under Section 13 for health hazards and 22 for communicable diseases, there is the ability to theoretically impose nearly any kind of measure at a local level in response to local contexts and local issues. And so that is often used if there is somebody who has tuberculosis and who is infectious to others, to require them to seek treatment and to not leave that treatment and isolation until they are better. Prior to the pandemic, there had been no instances of use of this notion of a class Section 22 order applying to a class of people rather than a single individual. My health unit through the pandemic did not put in place a single one of these class Section 22 orders, but other health units did. And what we saw was, as there was mounting concerns about the pandemic and risk in 2020, and as the province was perhaps delayed in acting centrally, some health units did go out and put in place required masking for their health unit. That was very atypical, and for legally risk-averse organizations was probably fairly challenging to navigate. But there was mounting concern, and there was a common consensus that the province was not acting quick enough. Here in Peterborough, we did not put that in place. This predated my time, largely because with this type of an order, one, it can be contested by somebody who appeals through the Appeals Review Board, which is called HSARB, and that could be that hearing could be within a matter of days to weeks, like even a couple weeks. Sometimes it's closer to a month, but if it was a politically high-profile case, the HSARB appeal could be within a couple of weeks. And HSARB could strike down a order if they did not feel that there was a local health risk that was different than the provincial context, right? The other issue with Section 22s from a class standpoint is enforcement. When we required masking in Ontario and a number of other things. So for instance, we required vaccination in coaches and volunteers for sports, which were not clearly articulated in the provincial requirements. So there's a few things that we deviated from the province here locally. All of that was done under ROA, the Reopening of Ontario Act, another piece of legislation that was created with the express purpose of allowing both the province and local medical officers of health of writing letters of instruction to businesses or groups of people around compliance. And from an enforcement standpoint, the enforcement was then on the policing services, not on health units. But from an enforcement standpoint with HPPA, the enforcement would actually be on us. So for a tiny organization with only several public health inspectors that already are doing infection prevention control audits and visiting high-risk restaurants to provide feedback, the entirety of enforcement of an order would be on our staff. So not only would that mean complete redirection and dropping everything else that they're trying to catch up on and doing, but it would mean the number of people that we have would make it effectively unenforceable. So the first piece is around HSARB appeal. The second piece is around enforcement. And then the third piece that I think is a real struggle is boundaries, because our boundaries are small and relatively arbitrary. We have lots of people that work and live in different health units. And for us to be doing something independent of neighboring health units would not only be confusing for the public, and they'd probably think it was more based on politics rather than a public health imperative, but it may be less effective as well because you may not really get prevention of transmission when it applies to one small little region with neighboring units not applying. So I mean, this is something I've been in fairly constant conversation with neighboring health units on, with our lawyers on, with our internal team on looking at. But the reality is the instrument that and especially on social media, people are calling on us to use this local power is not an appropriate instrument for effective implementation of this. And so what we've been left with is both internal and external advocacy. And I've been doing lots of that with a couple of other medical officers of health. A few months ago, we wrote to the chief medical officer of health advising that we felt from our perspectives it was really critical to bring back required masking among other measures. And I continue to obviously advocate around that consideration provincially, or at least more explicit, transparent information on what indicators would be to reinstitute. Because right now we hear from the CMOH that in the event of hospital capacity being overwhelmed, masking would return. But what I hear from our hospital partners is hospital capacity is already overwhelmed and there's very little buffer room. So how do we grapple with that? And I think pushing for more transparent criteria and clarity would potentially make this decision either easier. So the CMOH could certainly put in place similarly to my order something provincially, but it's still under HPPA, and it's not as effective of a solution as what we had before, which was the Reopening of Ontario Act, and and again be a cabinet decision because enforcement otherwise would fall on public health inspectors locally, very few of us trying to do other work and catch up on other important issues. And then finally, the question is, what kind of a message would actually convince people to reinstitute masking? And I think clear, consistent, especially central provincial messaging is going to be critical to that, because I'm already very strongly recommending and advocating through our COVID-19 risk index and the corresponding measures for people to start masking up again. But I think to go beyond that, we really need provincial support in that communication. So complex issue, Janet, but one that I think we'll learn more about and unpack even publicly in the coming months and years as we try to, I think, re-normalize and find a balance. The last thing I'll say is I don't think we should put sole emphasis on masking because we know a multi-layered approach is critical. So even if you require masking in certain essential service areas, you're not necessarily going to blunt transmission dramatically if people are still having the exact same kind of social interactions, or if people are going to work or school or to social activities sick, which I think I'm hearing a lot of. People are kind of forgetting the stay home if you're sick that we've done pretty good on through the pandemic. And if people are not catching up with vaccination. So I think masking's been a big one of contentious attention because it seems, especially to those that continue to wear masks, that it's such a harmless small thing we can do. So why wouldn't we to protect others? But obviously the political context and the values and preferences of people across the province is a bit more nuanced than that. So it's a tough issue, but something that I think a lot about and I think we need more dialogue on.
I could talk to you for hours. I have so many questions. I know we're running short on time now. So one other issue I just wanted to briefly ask you about, because it's something we're covering this week, is mental health and addictions. And I was just wondering what role public health plays in that domain, if any, if you could talk a little bit very briefly about that.
Yeah, it's an interesting one. So, I mean, formally in Ontario, there are standards around mental health and addictions, and especially the drug poisoning crisis within the Ontario Public Health Standards. In practice, not a lot of health units have done a lot so far. Most of my work to date has been advocacy and trying to support the implementation of a safe consumption site, this new CTS that started in Peterborough. And you can read back to some of the history. That was a politically very challenging one to navigate because there was some political opposition for some of the NIMBY and perhaps political views that people carry on the issue of addictions. Um, so that was a bit of a complex one, but there's lots that we need to do, lots more we need to do, and we prioritize that in our strategic plan. I can send you the link, Janet, but we have a new strategic plan that just came out in September, and it prioritizes especially supports for young families, including single parents, climate change related adaptation work, and response to the drug poisoning crisis. Those are three of the front and center issues that we've prioritized for our region. And so from a drug poisoning crisis standpoint, I think we need to do and support more. Formally, there's not a lot of money that flows to health units to do this work or to do anything about it. So we get left with more work on advocacy, perhaps, and working with partners. There is a real shortage in services, obviously, and we don't deliver a lot of services, at least as it pertains to mental health and addictions. So I think there is a need for more provincial funding and support for services, more equitable distribution of services, more equitable access to services. But a lot of what public health does and what we're doing here locally is focusing on the prevention elements, which are longer term solutions, including preventing traumas that lead to addictions in the first place. We know over half of people who use opioids have a history of trauma and are likely self-medicating for that unresolved trauma. How do we work from the earliest days of life to prevent some of those adverse child experiences? And the other piece, other than prevention, that public health has a really important role in is harm reduction, and we know that harm reduction is about meeting people where they're at and not necessarily having a focus on abstinence or cure as solutions, but keeping people alive in the context of a very poisoned supply of drugs. And it's gotten a lot worse in the last 10 years, to the point that drugs on the street are very, very toxic potentially, and nobody that uses drugs, especially opioids, wants to overdose or die from a drug poisoning. But when that's what's available, it's very complicated. So how do we allow people to use in a safer space, test their drugs? Those are some of the pieces we're doing with the safe consumption site. But also, how do we advocate for policy solutions such as safer supply programs, which is a bit more of a medicalized model, or interventions to actually eventually lead to the regulation of drugs, which we know for cannabis has probably resulted in some health benefits, not a lot of increased consumption, and then you can regulate. Control access, tax a little bit more effectively, and decrease the criminal elements of the drug trade. So thinking about legalization and regulation of drugs more broadly is probably an important piece for public health advocacy as well.
Wonderful, thank you. Well, I'll leave it there with my formal questions, unless there's anything else you'd like to add or share that we didn't cover with the students, especially those who might be thinking about a career in public health or health policy. I think you've been very inspiring in terms of the amazing breadth of things you can cover in this type of a career, but also it seems a little overwhelming. So
Yeah, it can be. What I would say is it's a journey and it's a process. But I think if you're committed to health equity or fairness, social justice, working in public health is a great way to focus in on that work and to do something about it. There's a great article that Ed Young and the Atlantic wrote on public health getting back to its roots. I'll send it to you if you haven't seen it. Maybe the class would be interested in reading. But public health has its origin in advocating for safer jobs, for safer work environments, safer living environments, sewage sanitation, vaccine campaigns to decrease the burden of infectious diseases on lower income groups and populations. And I think we really need to get back to that, especially with the large, very overwhelming societal crises that we're faced with around housing, around poverty, around addictions and mental health, around the climate emergency, around continued pandemics, which will continue to emerge. And all these things are unearthing, fractures of injustice in our society, in our very, capitalistic, class-oriented society that are unfair, and that, from a government standpoint, we need to do more to redistribute and correct. And I think public health is a great way of doing some of that work. And for me, my work in it to date, I'm still pretty early career, has been really inspiring. When you're able to make progress on these issues, you're not just helping one or two people, which is still important and valiant, but you're helping huge populations and communities, and saving lives and improving life. And I think that it's I couldn't personally picture doing anything else. I'm just so excited about what I do, and about the work. People working in public health are very caring and passionate, and want to make the world a better place. So certainly, if you're thinking about it, I mean, feel free to reach out. Happy to chat with folks. And talk a bit more about what I do, or what you can do in public health. But ultimately, I think it's a really exciting, important career, and is going to become increasingly more important as these big looming existential health threats just get more and more. So thanks for the awareness you're putting to this, and the work in the class, and appreciate the invitation to join you today. It was a lot of fun chatting.
It's been such a pleasure. And I think I can speak on behalf of all the future students to say we're so grateful for your time. You're juggling so many things and you squeezed us in. And I hope that that time has inspired at least some of the students to consider following in your footsteps. And if so, I think it was a valuable use of time. So thank you for joining us.
Thank you. Take care, everyone. Stay safe.